Good morning and welcome to our 23rd session of our monthly webcast, the ccclivecases.org. I am Samir Mehta, your moderator, and delighted to welcome you to watch another interesting transradial STEMI intervention. Samin, first of all, congratulations. You have become a proud recipient of the Ellis Island Medal of Honor, probably the highest recognition which immigrant to the United States could achieve. Our congratulations to you.
Thank you. Thank you. Yep.
And you have another wonderful guest who's joining us, Dr. George Dangus. I want you to introduce him as well as tell us about some important feedback which you received at the Fellows course in Miami recently.
Fantastic. Now, the one actually, as you know, both Roxana Mehra and George Dangus joined us last September, and because of the schedule, it has happened that we could never get George involved in the case. And I felt that this will be a very appropriate case today because it's a lot of functional discussion that do intervene or not to intervene, and knowing that George is connected to society guidelines and so will be very helpful. As you know, George is a professor of medicine cardiology and is the director of cath lab innovation and intervention, and has been a tremendous boost to our very expert interventional team since his arrival. So George, welcome officially, although everybody knows that you are at Sinai, but on the webcast you are the first time being shown here.
Always important to also have a presence in the webcast for official welcome. Right. Let it be today, May 17th. That's
good.
Great.
Now, second point, which was very timely, because we started this fellows guide wire course. Actually, unfortunately, that the first one I did in 2001 with Donald Bain. Reason, of course, you know that Dr. Bain's demise. The key was that there was no structured presentation for the guide wires, and we made it, and since then for last 10 I have done it with various faculty after having first two done with Bain. But the key is that about over 140 fellows were there, and all of them said that how they like this our live case symposium, our CCC live series, and very useful for them. The one thing I said, that if that is the case and it's a fellows is more for a learning point of view, so that why do you not ask some questions? We say, well, yes, of course, I encourage them, they should be asking more questions, and then say, you know what, the Dr. Mehta does such a great job, so that between moderation and so there's not much left, and really they understand everything very, very well. So having said that, also they said that many times there are more than 2 or sometimes even 10 or 20 people sitting, become a cath conference. So even we have this 3,000 hits, it's kind of a little misleading because actual people watching our total live and archive cases could be over 6,000, 10,000 or so. We don't have exact number, but overall this has been a tremendous I would say the educational feedback I got from both in ACC as well as from our this fellows course.
Samin, I think that is very critical, and I urge the fellows as well as the other viewers to keep asking us the questions. That makes it more interactive. In the meantime, we also have a very large group of people following us on Twitter. Continue doing that. 77 people tweeting and more joining in. Samin, take us through what you have in plan for today.
Great. Now this patient is, we can have our slide, presented earlier this month with a very kind of non-specific chest pain. I called it atypical, but clearly she has exertional dyspnea. She was climbing 1 to 2 flight and gets short of breath. And you really pinpoint the chest pain that was not typical, but overall they tried to do stress test, could not walk on treadmill, and they just sent the patient for cath. At that time I did a cath. Patient has a normal right heart pressure. Many times when patient have symptoms of dyspnea, we do a right heart which were normal, and we have found to have a 3-vessel disease, very calcific LAD with normal LV function. So the LAD has a multiple calcific lesions. We did ROTA, put 3 stents. Since then she was discharged on medical therapy and still have some shortness of breath. And as you can see at the bottom, she's a diabetic with the various drugs and good medical therapy. Her last hemoglobin A1C was 6.8. and well controlled on rest of the medical therapy. And now the second point was that since we have done the LAD, there are also other lesions in vessels with the circumflex and RCA. And the question whole comes that what to do with the patient with multi-vessel disease. You have fixed the very significant lesion and there are other lesions left. Should you diagnose, those who did not have a stress test to begin with, should you try to do a stress test again? Particularly more true in many cases of acute coronary syndrome and multi-vessel disease. Or you can do in the cath lab, guide them by the various tools which we have, which are basically the IVUS and FFR. And also now the OCT is the kind of a new kid on the block. We are trying to understand how it will fit into the equation. I felt that this will be a very timely case for this point, and I'll just take you through. If we can go back to angiogram, which has been done. Again, our emphasis has been the radial approach. See, this case is done by radial, and Anu can tell what is this diagnostic catheter is?
This is diagnostic JL.
JL 3.5, and see there is a large OM which will show another view, and then ramus in the middle, which actually will come up here. See, both of them looks about 70 to 80% lesion. Even for interventionalists, we all know that all lesions look very significant, but otherwise also I'm sure you show it to the cardiologist, they will say the same way, significant lesion. This is the LAD, which are the multiple, 3 stents, looks perfect. And of course, catheter we just put in the ventricle, very simple. This is what we are promoting, that put a diagnostic catheter where there is not an issue about the LV dysfunction or valvular disease. Just take a JR4 catheter into the ventricle, and of course with the Tiger or and Jackie catheters for the radial, take a picture, simple, so that you don't have to worry about changing the multiple catheters and putting the pigtail in the ventricle, because many times it's not the issue. And then this is the proximal RCA, another solid 80 to 85% lesion. So I felt that this is a very good case to bring this subject to our discussion in terms of the IVUS and FFR guided intervention, that where you don't have other tests to guide you, patient had symptoms and critical lesion has been taken care, that maybe now is the time to assess them, and if they are significant, then go after the intervention.
So, I mean, this is so critical, because I bet you this is what is happening nationwide in just about every case. Both lesions look moderate. The right to me appeared a little more severe than the circumflex obtuse marginal branch, but would be interesting to see how many people felt those lesions would be significant, but I'll let George Dangus deal with that. In the meantime, a quick question for you. The first intervention of the LAD, was it done transradial or transfemoral?
No, that one was done transfemoral. And of course, as I said also last time in our webcast, that once we talk about you have to puncture the vein. To me, it's easier just to do both till we get expert in the antecubital. Having said that, maybe it's the right time to get an input from George, that how would he basically manage this patient, and what does he think the role of these imaging testings will be in our the interventional lab, and also little input from the freedom, where the goal was try to revascularize as many as lesion possible which are angiographically more than 50%. George?
Yeah, great. This is a great point. This person would fit exactly the bill for the inclusion in the Freedom trial. Has a classic 3-vessel disease, mostly in the first proximal half of the vessel, without involvement of the ostia. The vessels are good targets for both, for distally for bypass. At the same time, the lesions are rather discrete, or maybe a little long, but still discrete, with a good landing before and after for PCI. So the Freedom trial is completing the follow-up next year, and in American Heart Association 2012 we will have the long-term follow-up. In the meantime, the strategy followed here was also the recommended strategy. Upon original angiogram, you fix one vessel, bring the person back, and do the rest of the work. And now, interesting thing is that no clear-cut lesion where to start and what to do, because the 3 lesions in the vicinity between 70 and 85%. Probably the most significant is the RCA between 80 and 85, but the OM and ramus are also very big branches. So this is the material actually these days of the FAME and even the FAME2 trial that tries to pick by using multi-vessel FFR, utilizing the adenosine infusion of which of those lesions would be significant with FFR under 0.8 and target there. There are several features that I think would be very useful to do this today, and I think we're set up to do the infusion of adenosine and the FFR, as well as using the same wire. We can also obtain an IVUS picture for more completeness understanding of the plaque volume. The way I saw all these vessels, I see that they would be characterized by some significant plaque volume and high remodeling, and probably they will be very highly significant by FFR, all three of them. Once we go to the specific vessel, I would like to discuss each one of them, but I think that would be enough for the introduction right now.
Good. Now, let's take a guess.
So, George, you're predicting all three lesions are going to be significant?
0.8, the
Let's
RCA, less than. Let's go to each angiogram, and I'll maybe people can tweet it also, our audience, that what do they think? FFR, significant, non-significant, cutoff 0.8. RCA, George, 0.8 or more than 0.8?
No, this I think due to the length and the stenosis, combination of both, and the very good non-infarcted distal territory, I predict this will be less in the 0.7 vicinity.
Good. Anno?
Yeah, will be less than 0.8,
8.
maybe
Good.
in the mid 70s.
All right, we actually have two of our fellows, guys.
Yeah, we have actually Vinod Patel, who is on my left, and I have Anuj Shah, who is on my right.
The fellows will probably get it right.
Let's see.
Yeah, they have been because we have our FFR guided trial that we do, and if you think this is they are a month before they are graduating from Sinai, both have got a job. Actually, Vinod will be joining in Florida, and Anuj will be joining somewhere here in Connecticut, and this entire case, getting the access, the angiogram, whatever they have done was done by the fellows. I was just by the side here. So, Vinod, what do you think is going to be the FFR?
Less than 0.8, more than 0.8, very simple.
Less than 0.8.
Anuj?
0.8.
Okay, good. Now let's go to the right, left system now. Ramus, George. Now, George takes the first.
Yeah,
less than 0.8, more than 0.8.
Ramus is highly significant, less than 0.8.
All right. AK?
Yeah, same. The OM will not be.
All right. Now let's go one by one.
Oh.
All right, both fellows are still saying less than 0.8. Now OM1, less than 0.8, more than 0.8, George.
Looks like it may not be, but I think it's still going to be significant. I see that being a little hazy. I think it will be very reactive lesion as well.
Okay. Anno?
No, will be like I mean FFR
more than 0.8?
More than 0.8.
Okay. Vinod, 0.8?
It will be 0.8.
Well, no, but remember they say the abundance of 0.8 is significant.
Yeah. So
the 0.8 and lower is significant, so that you are saying significant. All right, I say that I agree with all, except I agree that go with Anu that OM1 will be more than 0.8. All right, having said that, while they are, yes.
So, Sameem, if the fellows get it wrong, do they end up training more?
We will ask them some more prediction. Now, what I'll do is, as I do that another 10 minutes or 12 minutes, I'll take you through the topics of today. And meanwhile, we'll start with the right coronary. Anu, right, that's the plan, that we do the FFR and IVUS of the right coronary, and we'll come back and give the data. And as you see that in all cases that you start doing the right. Huh? Yeah, we'll show once you are ready. We'll bring it back. Yeah, once you are ready, we'll bring you back. Yeah, but once you are ready for FFR, I'll stop in between.
You'll have to zero and all that.
Yep. Yes, good. Good. Now, this case, as you see that we show the appropriate criteria for revascularization, this patient will be 3-vessel disease, although no medication at that time, as well as did not have any functional imaging, but because of 3-vessel disease will be appropriate. Now, I felt every time we'll just take 2 important topics, and today, because there was a lot of news about appropriateness use criteria in last 3-4 months, and of course in ACC, myself with Jean Turco and Krumholtz, we had a whole session sponsored by ACC on the heart.org about this appropriateness use criteria. And second is the status, or so for that matter, utility of IVUS or FFR guided PCI. The first is appropriate use criteria. As we know, they are more so for the stable patients than for unstable patients, and clearly need to be that various things comes into equation based on the earlier trials. And what happened is that since we did not have any guideline, that the committee was formed basically to come with the writing guidelines, and they actually had a technical panel. And this, the criteria came headed by Manish Patel from Duke in 2009 for the appropriateness. Now, basically, what they did is the writing committee came up with a 180 clinical scenario to mimic our common clinical situation. Usual cases, proximal LAD, mild symptoms, no symptoms, and so on and so forth. So they clearly had the clinical scenario mimicking 180. Then they asked a separate technical panel which consisted of cardiologist, interventionalist, and cardiothoracic surgeon. But many of them, or majority of them, were just the non-interventionalists. So that it's not that the interventionalists decided. So this basically the technical panel on those 180 clinical scenario asked to vote from a scale of 1 to 9. Now, what is a scale 1 to 9? That if 7 to 9 they average they voted, that means it was appropriate, that it's the technique or revascularization is generally acceptable and likely to improve overall health and survival. Uncertain, if they voted between 4 to 6, the revascularization may be acceptable but uncertain benefit. So this will be like class 2B of our ACC, and appropriate will be class 1. And then if it was between 1 to 3, which is inappropriate, that coronary revascularization is not generally acceptable and is unlikely to improve overall health outcome or survival. They actually kept away from that it was harmful, but clearly that I would say the class 3 becomes inappropriate. So basically this was the basis for the appropriate, uncertain, inappropriate, taken all the fact from the technical panel. And now basically what happened is they came up with the 4 important scenario in the equation: patient symptoms, stress test, and basically the maximum medical therapy which they counted has to be 2 anti-anginal: nitrate, calcium blocker, beta blocker, ranolazine, and coronary anatomy finding. And of course classification of the angina class and risk assessment, I have put it here for complete sake. But more important is they came with the 3 different scenario: one low risk asymptomatic patients, then medium risk and high risk. The low risk basically was based on your non-invasive finding or asymptomatic. And you can see here, I is inappropriate, A is appropriate, and U, just like our traffic light, that A, go through the green light, on the uncertain, maybe pause a little bit, I, red light, stop, don't go further. So clearly that the idea was don't do intervention in the inappropriate. Second is once you go to the intermediate risk group, the group I category becomes less, but again this is the intermediate finding. And then once you go to the high risk group, only CTO becomes the inappropriate, otherwise it's A or U. So basically, as I said, that U is okay, you try to be A, but definitely not I. And of course for the total occlusion they were very clear, you need to show ischemia on medical therapy, otherwise it's inappropriate in asymptomatic patient. Same thing is for the vein graft basically. And then what we have done, that we actually in every case at Mount Sinai we have this grid. So before the PCI is done, that the patient has to fit in to any of the grid, avoiding the red bar, that basically inappropriate. And that's our goal, that we don't want to be inappropriate. I would say 1 or 2% of scenario will happen that you don't have that scenario shown by the grid, but clearly there, if you still have to do PCI, has to be a clear-cut explanation. Now the second issue then they came, that if there is an advanced coronary artery disease, the significant multivessel disease, and so then choice of revascularization, they define CABG versus PCI, not for the routine. So the routine cases all should be done like interventional, but once you do a common complex scenario, whether 2 vessel disease with proximal being LAD, remember this is from the European Society where CABG is shown to be beneficial over medical therapy, but there they said very clear that PCI is okay, enough data to support that PCI is completely fine in those cases. Now you get to a 3 vessel disease, there we know many of the data to show. Yeah, you start going? Yeah.
Yeah, go.
Yeah, that with the 3 vessel disease, that clearly some studies did say that based on the burden, maybe 3 vessel disease might benefit with a CABG, but definitely PCI is not inappropriate. But once you get to the left main, with or without LV dysfunction or even isolated left main disease, the guideline in 2009, because this took them 2007 and 2008, came up with the inappropriate, the left main stenosis is inappropriate. But since then we know that this has changed. Now, until now we have no data to support what does it all mean. So basically the Paul Chen what
Right.
from Mid-America Heart Institute, what
Zero
he did,
up
what he basically did. Yeah. Are you ready?
Ready to equalize.
Okay.
That's
Now
not
I'm
sure
going to
what
stop
about the
here.
lesion.
If we can go to the come back to the screen for the FFR.
Samin, in the meantime, there is a very relevant question asked by Nick Helmy. He's saying, great case. Do you think it would be reasonable to proceed with the RCA and intermediate without further assessment and do a circumflex later?
Absolutely yes. If I would say in this, just to be purpose of doing these studies, the functional study is because we don't have any.
Okay, you want to start?
Yeah. That we don't have any functional test on this patient. Now, just because anatomically you're looking 80% lesion, is it causing ischemia? Only test would be FFR will tell you. So yes, clinical practice you can go ahead, but to be certain and to be perfect in that and clear that I would say FFR will help you in that.
Show the thing. Show the FFR. It's already 0.96 at rest.
Right.
0.96 at rest, and then
Now,
we'll see the
adenosine has been
follow-up.
started IV. Now, where is the wire? Wire is in the main epicardial vessel?
Yes.
Okay.
George, what is the protocol you follow, IV or IC?
No, we give IV.
The best is IV to make sure there is no escape.
Yeah.
Yeah, and already down to 0.76.
Okay. You can stop
within
it.
a minute.
Yeah, good. We stop it.
Also, what we see is that if you know it is significant,
Stop
as soon as
adenosine,
you
resume
start the
angiomas.
adenosine, so what you do is you equalize before you cross the lesion, and then once you cross the lesion, then you start adenosine. So if you know it's significant, by about 40 to 45 seconds, you will see a difference.
Yeah.
And many often, like this patient, they do have some symptoms because they can have
drive now?
bradycardia and hypotension.
Left
with
side.
this.
Good.
Anu,
Stop.
So that part is exactly right. What would be your strategy here? Would you direct stent or
No,
what are you
I
planning?
think what we'll do is we'll the same, since we
For the
need
wire.
this, we are going
to
to
live now.
take this out, wire it with a different wire, pre-dilate and stent it.
Okay.
Good. Now, while they're doing it, though, clearly that again, from interventional point of view, as Anu pointed out, we still do lot pre-dilatation, and many people will do a direct stenting and post-dilate, which is fine, but it's basically the practice pattern what you have. So clearly what they will do, what Anu and the fellow will do, put the stent in the right, and we'll come back when we are ready for the left.
Clean this.
Now let's go back to our slides again. So now basically that yes, the panel has come. Now question is, does it make sense? Until for last almost 2 years, since came in January of 2009, we did not have any follow-up. Now, very interestingly, from Mid-America Heart Institute, Chen sent basically did a very prospective analysis to 85 physicians, gave before the appropriateness criteria were came, and then send it to send after the criteria came, and then say that whether there was a concordance or discordance based on the scenario which have been described in those cases. So they basically came out to be that very interesting observation. Now you can see that for all physicians, if you take as a group, 84% were concordant. But where was the difference? That appropriate criteria, we just go to the first column, which is in the red. The appropriate criteria, 94% said before and after makes sense. But once you get to the uncertain and inappropriate, the number of concordance went down. So that basically, even if the technical panel which say that yes, it should be it was inappropriate, but about 30% people say no, it is appropriate. So that this was a discrepancy. But where the discrepancy was, which is the second part of the slide, that is interventionalist, yes or no. That you see that if there is a cardiologist that did the analysis of voted before and after, it was 100% concordance with the technical panel. Very, very interesting. So therefore, while for interventionalists, many of the scenarios they didn't agree, so 70%. So what is the take home message? Message is very simple. When you are doing a PCI, make sure you involve your cardiologist. If cardiologist says, you know, wait, this case should not be done, I think they have very good judgment. Yes, we know that we do a great job, but just to say that even with the technical panel, this is the fantastic. Continue with the second slide, and that part is, that second part which was presented from the ACC-NCDR registry by Paul Chen, and that is that if we take all the cases, because remember the ACC-NCDR has all the data of the patient scenario, vessel disease, medical therapy, and so they found basically that overall 84% are appropriate and about 4.1% were inappropriate and 11.2% were uncertain. Now basically, if you go to the acute coronary syndrome versus elective PCI was 29%. That acute coronary syndrome, we rarely do inappropriate, so we are good with that. But more importantly, that for the elective PCI, that there were 11.6% were inappropriate. So that was very, very interesting. So therefore, you need to look into this, that inappropriate based on the data which was submitted, based on the technical panel recommendation, were inappropriate in the ACC/NCDR of 500,000 cases. Then we actually had done analysis of the New York State PCI database, also about 58,000 patients, and we found inappropriate PCI based on the criteria. We are just talking about criteria, does not mean that there was not a 90% lesion, but based on the criteria, about 13% were inappropriate. Now, at Mount Sinai, we actually started this policy where as of 2010, we do 30 cases per month are randomly selected, and then they were reviewed by the separate non-interventional team headed by a nurse practitioner. And we had done over the last year data, I can submit to you that 6 weeks could not qualify because they were from our affiliate institution, that 74% were appropriate of the 356 cases done, 24.2% were uncertain, and 1.8%, which is 6 cases of the 354, fell into the inappropriate category. Now, each of this inappropriate, we go further that why PCI was done. I can tell you 5 of the 6 cases had a very significant angiographic lesion. So that did not meet the criteria, but clearly what we did this year, that now that grid is part of our cath lab, cath reporting system, so that before you do PCI, you have to have the non-inappropriate indication. If you're doing inappropriate, you need to make an explanation that why the PCI being done in that group. So that therefore, I would still say, knowing the data what we have at present, particularly from the focused ACC AHA update of the left main, that now no longer class 3, which is class 2B, particularly for the selected cases, that syntax score of 33, less than 33, that no longer class 3, and of course for the high risk patients 2A. It's very important that this I of this grid should soon become U. Now the second point is very again a kind of a wake up call to a very highly publicized paper came on Monday, last Friday, about again from ACC/NCDR, published in JAMA by Dr. Borden, not our William Borden of Courage trial, Borden, and they said they wanted to look the practice pattern of the at present of the optimal medical therapy before or after Courage, and they basically large number of patients, again like 500,000 patients, and it is very, very disappointing. I would say depressing for that matter, that optimal medical therapy pre-PCI or with a pre-Courage or post-Courage showed minuscule difference. Now because a large number is statistical significant, but of marginal clinical value. Same thing, the post-PCI number increased, but not that significant. The same thing they took from this 500,000 patient Courage trial, it still remained the same. So that it basically shows that there is a large practice gap in medical care of PCI patients, an important opportunity to develop innovative and aggressive strategy to increase optimal medical therapy in PCI patients, both before PCI, which is the responsibility in my opinion is of the referring MD, and after PCI by the interventional team is warranted. So clearly is an eye opener for us. Now second point is the status and the utility of the IVUS versus FFR. We all learned that moderate lesions sometimes have a very tight lumen, and of course the angiogram doesn't give us a overall view, and therefore could be a tight lesion. And this actually started many in late 90s by Washington Hospital Center, that cutoff was 4 millimeter square, that anytime you have a less than 4 millimeter square, you left it, had a high event rate, but more than 4 millimeter square was the lumen in epicardial vessel, then the event rate was very low. So that clearly the 4 millimeter became the standard criteria cutoff for the MACE. So that we started doing using the 4 millimeter as the criteria whether do a PCI or not on cases. Now for the left main, the number was anywhere between 5.5 to 6. Therefore it's very important that non-left main epicardial vessel, not the branch point. Average vessel size supposed to be about 3 millimeter. So once you have a small vessel, we don't have clear-cut data. I'll show you a little bit, but key is for the large epicardial vessel, 4 millimeter cutoff became the standard. Now, of course, then IVUS got into the various studies of the bare metal stent. This is the slide just shows benefit or no benefit. Again, I would say the jury was more of out there in terms of whether benefit or not, but some benefit, but not truly. But if you combine, maybe in the bare metal stent, for the drug-eluting stent, there was no clear cut, except there is no randomized. There is actually one randomized trial done by Colombo, a small one, again showed no benefit of the DES, IVUS guided or without IVUS guided. This is the comparative study from Washington Hospital Center showing that IVUS actually helped to reduce stent thrombosis. No other difference in endpoint. So IVUS may help in a tough cases, complex cases, where you think stent thrombosis, patient is unreliable or so, maybe you should do a IVUS to decrease stent thrombosis. One role of the IVUS seems to be in the left main, and this is again not a prospective randomized trial, but clearly that IVUS guidance associated in the main compare registry, lower death rate, lower MI, although insignificant higher TVI. But very important that IVUS may have some value in my opinion in the left main, but not others. Then second issue comes is the FFR. Now basically what is FFR as shown in this picture, that it's the gradient across the lesion after maximum hyperemia. And of course the IVUS is looking at the lumen, and if you take a CFR, CFR takes care of the microvasculature. So this is schematic diagram is very good. And when we call the non-reference CFR or FFR, we are talking about the non-target vessel, and then of course respective those parameters which I have shown. Now of course after the original Pills article in NEJM, FFR started getting lot of attention, and then really came to the light in the last 5 years by two major trials. One of them was that FFR guided or not guided or defer the intervention. That was the defer trial showing the 5-year outcome of the lesions which were more than 0.75 with the FFR. And you do a PCI or don't do PCI, actually avoiding PCI had a lower outcome of the death and MI, 3.3 versus 7.9. So that makes the point that your FFR is high, you can leave these patients, and there was no difference in angina. More importantly, there was lower death and MI at follow-up, so that you save money and you did good for the patient. But real the breakthrough of I would say FFR came from the FAME trial. Remember, the FAME trial was a trial of multi-vessel disease where about 1,000 patients, half were angiographic guided PCI, that any lesion more than 50% should have a stent, and the half had a FFR guided PCI. All lesions were more than 50%, and the plan was that all lesions in this 509 patients get FFR, and they were total like 1400 lesions. That if FFR is more than 0.8, then stent it, more than 0.8 don't stent it, less than 0.8 stent it, and came out to be in this 1400 lesion that 61% had a FFR of less than 0.8. 39% of the lesion had FFR of more than 0.8, so that did not have a stent. So the very, very important point from that point of view from this trial. And basically I don't need to go to the data, showed that 1 year and even follow up that FFR guided PCI was superior to angiographic guided PCI, and of course the less angina, less cost, less dye use, and without adding to the additional time. Now therefore it became the standard. Of course we have the now 2-year data, and now very interesting observation. Therefore you say, well, is there any correlation? Why they're not giving some medicine to her? Is there any correlation of the FFR with your with the angiographic severity? Very interesting. The paper by Tonino came in the JACC last year, and if you see, the point is very, very important, that if your lesion is more than 90%, you can consider your FFR will be less than 0.8. But if your lesion is between 50 to 70%, the FFR positive means less than 0.8 is only in 35% of cases. 65 will have a FFR of more than 0.8. So intermediate lesion will have a very important utility of using the FFR, and of course from 70 to 90, that if the 80% will have FFR of 0.8 and below. Now therefore, and of course as I mentioned, this is the 2-year data. So if I just put this together, that the functional revascularization using FFR in the cath lab of significant angiographic lesion can appropriately select lesions who will benefit from PCI without compromising patient safety and will result in less MI, MACE, stent use and reduced procedural cost. So it should be done in cases with 50 to 70% lesion before proceeding to PCI. So very simple and clear-cut statement. Now most important issue comes is, what about the left main? And we have seen many of the ambiguous left main lesion which are less than even 50% will have FFR of less than 0.8. Now this is a very interesting paper where they have a FFR guided left main intervention surgery versus medical therapy, that many of the 50% lesion appearing, that FFR will be less than 0.8. Well, that's the squares in the left lower corner. So that in ambiguous equivocal left main, the FFR becomes a very important observation. Therefore, in this basically they found that if your FFR was less than 0.8, go for cabbage, but your FFR was more than 0.8, that they have identical outcome by medical therapy up to follow-up of 5-6 years. Then question comes that what about combining FFR with the IVUS data, which is 4 millimeter square. Earlier data with the 0.75 we have it, but more importantly the recent paper, and that to me is the very important issue, and that is the basically they have about 200 this was actually the follow-up of the previous paper, that specificity and sensitivity, that MLD and which lesion is more significant, that clearly when your area of less than 70%, MLD 1.8, usually FFR will be less than 0.7. But in the latest time period, this is the best paper which was just published and had been talked quite a bit in the literature. That is the correlation of IVUS with FFR in 236 intermediate lesions, which were 40 to 75% in 201 patients. And very interesting observation, that in these lesions, that if you have the overall you take about 236 patients, FFR of less than 0.8 were present in 49% of 49 cases. That means 20% of patients, 21% of patients had FFR of less than 0.8. And very important also, a second observation was that there was a strong correlation with MLA, mean lumen cross-sectional area, with a 2.4 millimeter square. That if you are less than 2.4 millimeter square, that if you are less than 2.4 millimeter square is kind of a best predictive value. Now how best predictive value? You can see that if your lumen is more than 2.4 millimeter square, which is on the left side, FFR of less than 0.8 will occur in a very small percent of cases. But if it is less than 2.4 millimeter, still that the many patients will still have FFR of 0.8. So that sensitivity is quite good, which is about 90%, but specificity still gets to about 60 to 70% because of the many of these FFR, these cases will have FFR of more than 0.8. And what they found, the predictive value within less than 2.4 millimeter square is that your plaque burden more than 80%, and your of course the longer lesion length were very important predictive of the significantly lower FFR of 0.8. So that therefore I would say that at present, compared to in the past when we had a 4 millimeter square with 0.75, this should be history. What this data recent are, the 2.4 millimeter square and FFR of 0.8 have the best correlation in terms of the cutoff value, where their operating curve, and you can see specificity and sensitivity is very, very important.
Equalize now because it's higher.
And we are just going to come back to this. People do say that, you know, what you do FFR versus IVUS guidance, there are some data to show that if you go with the IVUS, your PCI, you'll do more PCI, 3 times more PCI than FFR without change in any outcome. So that having said that, I'm done with my presentation. And we are coming back to they are doing the lesion which
now entire presentation this should never showed our movements.
OM just started the infusion.
Anu, have you already taken care of the right coronary artery?
Show the RCA first.
Anu, do the RCA while we're infusing on the OM.
Now this is RCA, got a stent. What is it? Go to the Flora. Tell Anu what stent you did.
Yeah, we just pre-dilated with the 275 high pressure balloon, and then we put a 3O 28 Zions, and just post-dilated the proximal area.
Excellent. That looks very good, and I'm glad today you are maintaining the emphasis on the FFR. The lesion was of course technically straightforward.
Significant.
Now you have the FFR for the OMB.
OM. Yeah.
OM. Wow. 0.74.
Okay, so this exactly is where we needed to demonstrate how one can be, even the expert interventionalist can be wrong.
Well, it's just basically we are not expert in FFR yet.
Not expert in FFR yet. No,
Yeah.
well, the two things I want to make regarding this, the haziness and the length of the plaque has something to do with FFR, which is not very well
Let's go to
understood
IVUS.
and it
Which is
shouldn't
to
be.
IVUS. Put your
But
brother
the
wire.
short lesions are not having such significant FFR. When the lesion becomes a little longer, like this one, about 15 millimeters, these tend to be more significant for FFR.
George, that's a very nice
short of it.
observation, and to be perfectly
Let it
fair,
run.
that is exactly what you had stated before
live.
doing the FFR, that you were quite convinced that the lesion length as well as some haziness, which I didn't
yeah, go
appreciate.
live to FFR for a moment. Anu is demonstrating something very important. This is a so-called FFR pullback technique.
Yeah.
That you pull back, pull the lesion, go to the proximal right, Anu.
Yeah.
To the proximal right.
Yeah.
Yeah, go to the proximal, a little bit more proximal to the OM. You see that now the FFR partially normalized to 0.9 during the infusion over there. So there may be some contribution from
Pull back a
the
little bit more.
angulated circ in the beginning, but not much. But you see that that's another
Okay, let's
technique
do
we can
the
do
high lateral. Should we do or not?
with the
I did
FFR.
IVUS. We
You
need
can
to
do
IVUS.
pull back and
We need to IVUS.
sort of
There's 15
assess
minutes.
the
One by
contribution of the different lesion segments.
That's already
A final point I want to make that's very
Do
important
I?
for the FFR to also assess where the vessel goes. Sometimes we're fixated on the lesion, but you also need to understand the FFR has something to do with how much resistance you have downstream. And the bigger the territory and the healthier the territory, even not as significant lesions may become significant. And this is something also we need to understand. A lot of people tell me, oh, you know what, I had this 90% diagonal lesion and FFR is 0.9. Why is that? Well, two reasons. Number one is probably an ostial focal lesion, and more importantly, that diagonal may have a very small territory, not as important. That is somehow reflected in the FFR versus you see a very large marginal with a big caliber and a healthy myocardium. Even a more than like 70% or maybe 65% lesion was significant.
Very important. I actually remember that the latest paper of from Korea, FFR, and they actually put that every 3 millimeter lesion addition for the length has a very predictive value, getting to the FFR of 0.8. So that lesion length, therefore, even a moderate lesion with a long lesion will have a positive FFR, and compared to a longer lesion, short lesion, even 90% may have FFR of more than 0.8. So the very important what we learned, that in addition to the lumen cross-sectional area, the two important things comes in. One is the plaque burden, and second is the lesion length. So they really, particularly in those significant lesions, that you want to get to a more diagnostic accuracy and specificity, the lesion length and the plaque burden comes into equation. So that now, having said that, and particularly I have already lost the bet on this FFR, I want to, we are doing the IVUS for this OM. Now we want to take a bet on this, whether the lumen will be less than 4 or less than 2.4 millimeter square. It's a large vessel, 3.5 millimeter, 3.25 millimeter vessel. So the question is, whether IVUS point of view, is this lesion significant, and what the criteria, as I mentioned, that in my opinion now it should be 2.4. Yeah, okay, let's go to the IVUS.
George, what do you feel the IVUS is going to show for the OMB?
I think the IVUS is going to show a tremendous plaque burden. I'll talk a little bit while trying to do the connection. The IVUS will probably show a very big plaque burden and positive remodeling with a significant cross-sectional narrowing. I think that the lumen is going to definitely be less than 4, and it will approximate the 2.4. I don't think it will be below, but you know, I think it's going to be very close.
George, excellent points. Have you completely abandoned CFR, or do you do it in some cases still?
No, CFR has been abandoned because it has tremendous limitations in patients after acute coronary syndromes, etc., which do not exist with the FFR. Now, one point I want to say, staying in IVUS, Dr. Sharma mentioned earlier about IVUS in drug-eluting stent. I want to give you ahead of publication news that in a large study of 1,500 patients with a first-generation sirolimus drug-eluting stent in the Matrix registry, very contemporary, with actually very low stent thrombosis rates, very good clinical results. We had, and it's coming up in the JACC cardiovascular interventions in the summer. We have a significant reduction in the composite of death or myocardial infarction with the use of IVUS. And this will be, I think, an interesting addition to the data from Korea Dr. Sharma showed that indicate also there may be some benefit there. And again, this was a real world population, not a study population. Therefore, we treated long lesions with a lot of plaque and all that. So the use of IVUS to optimize the result had something to do with a very low stent thrombosis of 0.9% over 2 years, exceedingly low for a real world population. And in addition, the first study that showed the the reduction of death or MI in contemporary series.
George, excellent fine points. Let us also take some advantage of your presence there. Samin raised a very interesting point today about the QA process in the cath labs. Do you think the AUC grid should become almost additive or a requirement in the cath lab doing their own analysis?
I think that every cath lab that has some type of database or a QA process established should incorporate that, as well as the syntax score analysis for multivessel disease. And any cath lab that does not have it, they should develop it. I want to tell you that there is a work in progress in the American College of Cardiology to actually develop a module that the cath labs who do not have established QA programs could participate by sending the films for review in addition to 1 page of clinical information, including the appropriate criteria, into peer review committees from other states in order to regularize that and actually enable the fact that some hospitals with few operators have really practical issues on exactly how to implement that. So the college, in association with the Society of Cardiac Angiography and Interventions, are going to offer a good alternative about those things and allow these reviews to be done out of state by experts, for example, like you or us, with respect to cases done in California or Nebraska and vice versa.
Yeah, and actually, as you know, that for the New York State, we did a survey of 54 cath labs who do PCI in New York State. And it was very alarming that only half of them had a QA process in place. Other half did not have any formal QA process in place, so that Mount Sinai has been designated because it be involved in so much QA even before all these things had come to the limelight, the designated training or vanguard site for the entire New York State. And we actually, many cath labs have approached us to come and duplicate what we had done from the angiographic stenosis point of view. The second is from the appropriateness point of view, and third point we do from the syntax score point of view.
Samin, I'm sure there is a lot more educational value to that rather than just being a big brother.
Right, absolutely. The key is basically because this what we have learned that because so much in the news about inadvertent use or unscrupulous and overuse, unregulated. So we interventionists have to come up with own plan. Rather than some government agency comes and try to regulate us that what to do, what not to do, it's better that we have our own, and the SKY actually has taken a very good stand. They came up with a very nice document clearly delineating that what should be the requirement for the cath lab QA process. Now,
absolutely right. More important for us to self-regulate in a scientific manner.
We're ready for the IVUS meanwhile, and you see the distal reference vessel segment of the OM. It's a 3.0 vessel with minimal plaque between 3 and 6 p.m. and now it's pulling back, and soon we're going to see the lesion emerging, as you see, is from the bottom around 3 and 9 p.m. still in the relatively reference segment, but now we're entering the lesion, and you see how the plaque burden starts. And now it almost encompasses the catheter very soon, as you see, right? This is the tightest part. It's almost around the catheter, and a significant remodeling. I think this will be under 2.4 in this, and there's a calcified area. Can we see angiographically where this follows? Okay, that was pulled out. Okay,
fine.
Great. I think it was the area, but within 3 millimeters below the bifurcation, it was the tightest part.
Right.
And we can do this analysis now.
Analysis of this. What do you think now? What should be your strategy now? There was little calcium on the top, but just very small arc.
Give the pre-dilatation.
You do an angioscope or a high pressure?
Yeah. The question is just a pre-dilatation balloon and then stent it. And then, of course, after we stent, we go to the third hour, the ramus. And that will be hopefully will quickly done
this is
in this
20,
IVUS,
right?
and then we go to the third part. But anyway, go to the lumen. No, this is not the tightest one.
That's approximately with the calcium.
Okay, yeah, this is it. Actually, show it. It's a 2.24.
Okay, exactly.
2.24.
Therefore, clearly the increasing the new data of 0.8 correlating with 2.4, and
Good.
this actually we are in our lab trying to make it that 2.5 should be cut off. That because it's a 2.42. So if you're less than 2.5, IVUS now with the epicardial vessel should be 2.5. There's no question in my mind that should be our new gold standard, not 4.0.
Go.
Yeah, it's a very large vessel. You want to put a 3 or 3.5?
George, what's happening? What's the new and the latest on virtual histology?
Virtual histology and still under evaluation. I think this person would be a characteristic of an example for a thin cap fibroatheroma with mild calcification components, and the OCT might also be a very important new tool because it would let us understand if there is the fibrous cap thickness and all that. I suspect the lesions of this person would be all in the vulnerable vicinity. This person has significant multi-vessel rupture plaques at some point. Some of them healed, as you see the ones now, and some of them were responsible for the non-ST elevation acute coronary syndrome that patient had in previous admission. They characterized by the fact that these vessels are very large, between 3.5 and now there will be a 3.5 high pressure balloon inserted in this vessel. They're really very large, and therefore when the vessel is large, always you have to suspect ACS type lesions with healed plaque ruptures. The vessels are small and calcified. You usually have a positive remodeling type of negative remodeling type of lesions and calcification. And now the 3.5 stent, as I said, actually I said balloon before, 3.5 stent is going in.
3.5, 28, Anu?
23.
23, all right. And,
And
what stent type is this? This is a
Zions, and same.
Okay.
You can see the middle one is still not fully expanded. We can take a 3.25 high pressure balloon to post
We
dilate.
have 3.5.
Maybe we make
3.5.
one more
Down,
comment
down,
here.
Yeah.
This person was tested for a clopidogrel assay when upon the previous admission the platelet reactivity units was 212 and was tested again today after some time on clopidogrel long term, and the platelet reaction units were 150.
Good.
So the patient has been consistently found to be responsive to clopidogrel, something that has become under criticism after the Gravitas trial of elective patient, but most data previously very applicable in ACS patients just like this one, and actually in my opinion very applicable, and still could be used as a tool to re-stratify the patient, let alone that in this ACC data from Italy were presented that for the first time the platelet reactivity unit under 188 were associated with somewhat increased bleeding.
Yep.
So we'll be watching this in this patient, and definitely anyone with a platelet reactive unit under 180 after this new data should probably not be a candidate for the newer agents, more potent.
Yeah, and actually that's a very important point also. Remember, a lot of people say multi-vessel diabetic, you should put patient on prasugrel. Yes, but there's no data in elective PCI. So this was now elective PCI, so that even on the clopidogrel, this patient has a good inhibition. So that
Very
yes,
good.
we know that many of the diabetics will not have a good inhibition on clopidogrel, but large majority of them will do.
That's an example that of the protocol we use for patients who return for the cath lab on clopidogrel. In this cath lab, we test them for this reactivity, and if there is a very good reactivity on clopidogrel, we keep them on, and if we find some deficiencies after a steady state long-term clopidogrel administration since the previous PCI, then we consider them for 5 or 10 milligrams of prasugrel based on the risk for bleeding. And you have utilized quite, I think, interestingly, the 5 milligram dosage that in general has been understudied in other labs. So now we're going to go to the Ramus to do the FFR first.
That is the only last thing left. We'll do a PCI based on that, but we are going to go to the FFR now.
George, how do you deal with the fact that there has been some plaque shifting and the ostium of the circ in the AV groove? Just leave it alone, the flow looks to be good, it's a small vessel, or when do you try to intervene?
Exactly as you said, I think there's always a lot of spasm related to this acute ostium-related compromises, and even with time this will get better, but more importantly, as you said, this is a very good flow and a small vessel, so it's inconsequential. Sometimes we have to say that people get carried away because the caliber, the diameter of the vessel is big, of the side branch is big, but you always have to remember to check where does it go, what's the distribution, and as you see here, this distribution is mostly for the atrium and for small parts of the ventricle.
I'm going to also, George, seek your wisdom as a prognosticator on this. Where do you think the results of the rival trial are going to take us? There's going to be any change in the transradial, or?
I think we have been grounded with the transradial. I think the rival trial was somewhat important, however, represent a little bit of the hubris of radial intervention. They carried away and thought that they could even reduce death or MI, the hardest endpoint in PCI, something that PCI itself is not able to affect just by selecting a different axis. I think that was an overreaching endpoint. In addition, one can say that even with a access site complication, if people are in the context of a trial and very careful, it can be the bleeding complication on the access side can, except for the hematoma, can be very much controlled with the
use of bivalirudin.
I think this
use of bivalirudin actually was very small in the rival trial, so it's not exactly applicable to, let's say, our practice on Mount Sinai, but we could see about that. But clearly, there is a place for the radial, for patient convenience and patient liking, and relatively moderate cases this could be used. So I think now we've tried to reach a little bit the equilibrium.
Right.
Let's go back to the FFR though.
How do you feel the wire movement? I saw it that you went through quite easy. I know many times this wire is a little difficult. How was it?
No, this is a very difficult wire to manipulate.
Samin, also we should let your fellows redeem themselves by predicting what do they expect to find with the FFR of the ramus.
So far they have done a great job, and now it has crossed the lesion. There is a slight resting gradient of 0.9, and the question is the intravenous. As you remember, the 140 microgram per kilogram actually relates to that you need to infuse that in the central line. Because otherwise it takes more time, but we have seen the many times just given by the periphery. If we have the venous sheath in the groin is fine, that by giving in the periphery that for about 3 minutes, right? Because I know has been done very complex trial using IVUS, the basically infrared spectroscopy and FFR with the virtual histology, and the yellow trial which is ongoing, and based on that maybe Anu, can you tell us that how much time it really takes if the lesion is significant when we start this intravenous adenosine?
You should see by 45 seconds.
45 seconds.
1 minute, 35 minutes, not going to.
Now, some of these cases, to be sure, should you give intracoronary about 100 or 150 microgram?
We can give a push.
I think it gives you a false result, but in the rare cases where most rare situation, what you can see that it causes extreme bradycardia, chest pain, and if they start having hypotension, you may have to increase the blood pressure. You know, both your systolic as well as your, since this is, it calculates only the mean, as long as your both pressure, means the pressure at the tip of the transducer and the pressure of the guide, both are increased, so your mean remains the same. Rare time you may have to give a bolus, but it's not recommended. But now if you see here, we are reaching almost 2.5 minutes to 3 minutes.
Well, the
patient is moaning, which could be post PCI, but many times they have this very uncomfortable flushed feeling, which is due to adenosine. Is it going in the IV?
The interesting part is that this lesion is rather short, the tightest part. There is another part that is not as short, not as good. We can take a picture right now.
Other question also can come is if you want to do it in a vessel which is very tortuous, this wire is not a user-friendly wire.
No.
As soon as you done used it once, the second, third time, if you can see it here, it has multiple bends. The wire has multiple bends already. Then you may have to wire it with your regular workhorse wire, and then you use FFR wire. But when the tip of the wire is past the lesion, when you know the transducer is distal to the lesion, you take out your workhorse wire out, and then you start your adenosine drip.
Okay. Now, would you want to complete this one because we'll reaching to the end of our symposium
I think
now?
let's complete the FFR 0.93 and we can run the IVUS and see what it shows.
Right? Right? I mean, the FFR negative?
Negative.
Clearly. So that we were wrong or right, but one of the vessel on the left side, it was not the OM. OM was less than 0.8, and the ramus, which seems to be, we felt that would be less than 0.8, is actually 0.91 to 0.93.
So clearly, based on this, you are going to leave the ramus alone?
Absolutely. And that's what the whole purpose. And actually, people have seen that in FAME trial, and they actually have followed that what was the contribution of the lesion which was left. Did that patient presented with MI? They're found to be a one lesion. Therefore, so rare that your lesion will cause myocardial infarction. So that we come back to the point, and we are just finishing it up. You want to just put our other wire and see. Now, therefore, just to take some take-home message, the transradial PCI and functional testing, as you saw, 3 months in a row, we have done all kinds of intervention with the transradial, complex, ROTA ablation, bifurcation, FFR, IVUS, and so. They're basically expert in transradial should be there so that you don't have a high threshold in cases where there is a higher bleeding or a vascular complication. Also, there is strong data to change our practice from anatomical revascularization to functional revascularization in patients with multi-vessel disease undergoing PCI. Such practice will result in overall better long-term outcome. And it was very interesting. Based on the FAME trial, there were either 2 or 3 vessel disease. But after the initial 2 or 3, they reclassify patients to 0, 1, 2 or 3 vessel functional disease. And I can tell you that when you have the 3 vessel disease, they were like 9% were 0, means there was no disease because FFR was more than 0.8. And same thing with the 2 vessel disease, 12% had no disease. So clearly that we should be talking more of a functional disease rather than anatomical. And lastly, the routine functional or physiological imaging should be the integral part of our interventional practice, both for the quality as well as the patient safety point of view, where more data favors FFR versus IVUS in improving long-term outcome and reducing cost. With that note, I just want to remind everyone and invite for this our complex coronary vascular case symposium on 15th, 16th, 17th and 18th, and particularly on 16th and 17th, where focus would be on the radial, bifurcation, left main, total occlusion, and of course endovascular intervention on 17th will be the focus of this symposium. Now they are doing the IVUS just to see that what is the concordance of the lumen with the FFR, and again based on the data should be that FFR should be definite, the lumen should be more than 2.4 millimeters square even in the tightest area, but of course this is what we are going to test now.
The distal vessel you see is similar to the other, to the OM, is about a 3-0. Now the plaque emerges from the top this time between 12 and 3, and now should be the tightest part coming up, and I'm sure it will encompass the catheter. The characteristics is calcified 270 degrees. The cross-sectional area is under 2.0. it's
Okay, there.
but mainly
Yeah, tight.
we're talking about a calcified, more chronic lesion without a lot of plaque, without a
Where's the
huge
cross-section
plaque
area
burden and positive remodeling as the other lesion. So this seems to be more of a stabilized, chronic, or obstructive lesion. That's interesting to see that it's not so reactive, this type of lesion. So the consistency of the lesion have a lot to do with actually how why the discrepancy between IVUS and FFR. I wonder if virtual histology or the OCT might have helped us. Perhaps next time we investigate something like that, we should use one of these modalities.
So George, again, based on these results, you are still going to let the FFR supersede the IVUS findings?
Well, that's a very, I'm not sure that what should be the right one, particularly if it is meeting the criteria of your 2.4.
Below 2.0.
It's actually, you know, that tightest area.
But you're looking at a 175 here.
Yeah, that's exactly, it's less than 2.0. But now I don't know, I don't think the literature tells us many of these cases.
To show us the big plaque burden.
So there's a large plaque burden. You see the plaque burden will be, I would say that now I go with a plaque burden more than 60 or 70% if we do a vessel size.
How much did you get cross-section area there?
1.6. 1.6 millimeter square.
So this is, I mean, exactly the confusion and the dilemma a lot of people would have. You started by using two technologies. We created a base saying that FFR should be the functional criteria, and now there is a disparity with the IVUS.
Yes. I can tell you that it's really tough to say what should supersede and so, but from the plaque area burden is 86%. So that I would say that clearly that, you know, these will be the, remember anytime, because this is the continuous scale, that what your FFR is and where your the lumen cross section area. There are few cases which will be outlier. So this case will be outlier. But I would say that based on the judgment, because of the lumen being less than 2.4 millimeters square, and it's a very large vessel.
So look at the angiogram. Anu wants to give us the areocaudal in order to see how big those vessels are distally.
George,
pan. And you see there is a flavor that this vessel, the ramus, may be a little smaller in distribution than the OM. So that may be another player. Maybe a little more chronic lesion, a little bit smaller myocardium distally, that might have played some role into the FFR. Clearly, I think there's a significant lesion that, clearly we could stage for now or we can do it, but as you see here from this view, you appreciate there's a difference in caliber as well as in distribution of myocardium.
So I'll ask Annu, that clearly it's my patient, she's the operator. Annu, what do you want to do? Stent or not stent?
Stent it.
Stent it. Okay. Now with that note, I think we complete our this morning symposium. We were able to do, and just to highlight that we have many technology, still there is a lot of some questions, some cases will be overlapping, then you make your good clinical judgment in that case. With that note, I'll ask Annu to make a last statement, and we end for today's our webcast.
I just want to say that I think this entire case has been done by both my fellows. On the other side, I was just in the center to let them do the case, and I think we should get just a feedback from them how they have felt this entire year and what has been their training outcome. Yeah, Vinod.
Actually, this training was amazing. In the beginning, we started doing complex cases, and at the end of the year, we are expected to finish about 600 interventions, more than 600 interventions. And probably each of us has done about more than 50 complex cases involving ROTA ablation. And we have also used different technology during this fellowship training, including IVUS, FFR, and OCT as well. In addition, every fellow has been a part of very complex research projects as well. And I think this fellowship has to offer a lot more than most of the programs in the country.
Yeah,
this has been an exceptional training. We have done a lot of complex cases, as Vinod mentioned, ROTA cases, bifurcation cases, CTO, and we have been primary operator in more than 50-60% of the cases, especially in last 6 months. So we can't ask for anything more than that. We thank Dr. Sharma and Dr. Kinney and entire staff.
Anu?
Yeah, I think with this note, we just want to complete this case, which you see that so far we have always shown the complex cases and technically challenging cases. So this is a case where I think a little bit more thinking is involved, and more important, like Dr. Sharma showed, which is coming into the limelight, is appropriateness criteria, where you involve the referring doctor, the stress test, what medication the patient is on, and then involve the patient's angiography. So you incorporate everything and give the best to the patient so that appropriate things are done to the patient on the long term.
All right.
Anu, thank you so much, and you've always been gracious in giving credit to your fellows. I wish them good luck with their ongoing career. I think also as a last point to take home is the further need for us to augment and optimize our medical management. That truly is a disappointing data coming from the post-Courage. Join us on June the 21st, which is also our second anniversary. George Dangus, I want to thank you. Please come back again. Your input today was very valuable. With that, we conclude our session, and we'll see you on our 24th session on June the 21st. Thank you.
Bring that camera again.